So now the staging guidelines of the CA esophagus. The most recent guidelines established by AJCC for esophageal cancer. They are outlined here in table. A summary of the major changes between the current and the immediate past 7th edition staging system are highlighted, and the most significant changes is that in addition to separating by histological classification, squamous cell and adenocarcinoma esophageal cancers are now classified separately based on the temporal relationship to treatment. And staging prior to initiation of any treatment is deemed clinical, and after esophagectomy it is classified as pathological, that is PTNM. And the staging following preoperative therapy is clinical, and post neoadjuvant it is YP. And the cancer involving GE junction with their epicenter within the proximal 2 cm of the cardia, Sievert 1 and 2, are classified as esophageal cancer. So this is important. So GE junction tumor in the proximal 2 cm of the cardia, they are classified as esophageal. And the current AJCC guidelines do not classify number of nodes to be removed, but instead suggest that the surgeon resect as many as nodes as possible while minimizing morbidity. And further refinement in the staging of esophageal cancer may result from incorporation of computational modalities such as nomogram and artificial neural networks that may predict outcome better than the tumor necrosis metastasis based staging, TNM, tumor necrosis metastasis staging system. And successive pathologically determined stage groups are predictive of length of survival. Overall survival of adenocarcinoma and squamous in patients treated with surgery alone staged by new AJCC is outlined. So Tx is tumor cannot be assessed. T0, there is no evidence of primary tumor. TIS is high grade dysplasia defined as malignant cells confined to the epithelium of the base by the basement membrane. T1 is invading lamina propria, muscularis mucosa or submucosa. T1A, tumor invades lamina propria or muscularis mucosa. T1B, tumor invades submucosa. T2, tumor invades muscularis propria. T3, tumor invades adventitia. T4, tumor invades adjacent structures. T4A invades pleura, pericardium, azygous vein, diaphragm, peritoneum. Invades pleura, pericardium, azygous vein, diaphragm or peritoneum. And T4B, tumor invades adjacent structures such as aorta, vertebral body or airway. N stage NX regional lymph node cannot be assessed. N0, no regional lymph node mets. N1, metastasis in 1 or 2 regional lymph nodes. N2, metastasis in 3 to 6 regional lymph nodes. N3 is metastasis in 7 or more regional lymph nodes. M0, no distant mets. M1 is distant mets. GX is great, cannot be assessed. G1 is well differentiated. G2 is moderately differentiated, and G3 is